Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. Welcome back to the podcast. I'm Dr. Stephen Hunt, and I'm one of the sports medicine specialists at Tri-County Orthopedics. And I have the pleasure of introducing Dr. Paul Lombardi, who's the president of Tri-County Orthopedics and one of our joint replacement specialists. So today we have the interesting topic to discuss about the evolution of outpatient total joint replacement. So we're going to start off by Dr. Lombardi, maybe tell me why you chose joint replacement as your specialty within a variety of orthopedic specialists.
Sure. Thanks for having me, Steve. So when I was going through medical school and then residency, joint replacement just seemed to click for me. It's a wonderful specialty in that you can restore someone's function and rid them of pain in a way that's just very rewarding. They come into the hospital disabled, and they come out of the hospital walking, and in a week, they have their week to a month, they have their lives back. So it's just a very rewarding specialty.
And so to get to that point, you obviously did a fellowship. Where was your fellowship?
At the Hospital of Special Surgery in Manhattan.
Okay. And you've been part of this area for how many years?
So I started practice in 1999. I've been in practice for 25, going on 26 years.
It's a long time to be in this area. So in that time, I was 20 years ago when we were, in training, our joint replacements would come in, have surgery that day, spend 2 to 3 days in the hospital, go to rehab for 2 weeks, all being inpatient facilities. So we're here to talk about outpatient joint replacement. So what has changed? How has this evolved to that situation?
So the evolution of hip replacement is really quite a marvel. Initially, when it was first designed by a surgeon, John Charnley, the patient would be admitted 3 days prior, would receive a bowel prep, and actually would be in the hospital for up to 3 or 4 weeks. So over the course of the last 60 years, surgical techniques and thinking have been driven by how to make the patient experience more patient-friendly, so that now surgical techniques have been advanced to the point where they're much less invasive, and our pain protocols are much more advanced, that we can now have a patient have their surgery in the same day in a safe and effective manner.
So I think there has been a push across medicine, certainly over the past 15 to 20 years, to get patients out of the hospital whenever possible. So what are some of the specific things about, let's take total hip replacement, that have enabled you to take patients maybe at a hospital situation and still have them be an outpatient, or take them to an outside surgical center and do a hip replacement same day?
So what we've done are developed protocols to identify which patient populations are safe to have an outpatient surgery. Now, they could have an outpatient surgery in a hospital setting or outpatient surgery in a surgical center. By developing the proper surveys and sort of identifying the information that can give you the ability to make this kind of decision, that is what has enabled us to identify specific patients who would benefit from an outpatient procedure.
So, for example, if someone listens to this podcast and says, I've been told I need a hip replacement, I want to know if I'm a candidate, what are some of those specific factors that you're looking at during that initial visit with the patient to say, hey, look, this is a great candidate for this, or hey, look, you have some issues that maybe that's not the right thing for you?
So the first thing we look at is the patient's medical history. So if they've had any kind of real cardiac history, if they're on any kind of blood thinner medications, or have other things that have left them with a chronic disease, they could still potentially have an outpatient procedure, but we'd rather have that in the hospital where there's the backup just in case, just to keep them safe. But someone who has relatively clear medical history, they would be ideal for an ambulatory setting. The second issue we look at is a patient's orthopedic history. If someone has a very clear-cut case of osteoarthritis of the hip that's not complicated to fix, those patients are clearly candidates to do in an ambulatory care setting. But if someone had prior surgery, if someone's had a birth defect or a congenital issue in the past, those patients require much more technically difficult surgery that is better off done in a hospital with an overnight stay.
So once you've identified someone, say, who's a candidate for an outpatient total joint replacement, how about some of the evolution of, let's say, instrumentation or surgical techniques that you think have made this something that can be an everyday event, not just a once in a blue moon event?
So when I first started practice, the approach that was the dominant one was the posterior approach, which is still certainly a very good approach today. But over time, we've developed the anterior approach, which is a approach that is done where we spread through muscles and tendons instead of cutting. And that has allowed us to advance the operation with respect to having it in the ambulatory setting.
So yeah, I think that sort of pushes us into a different topic, which maybe we'll cover again, the pros and cons of an anterior versus posterior approach. Because it is true that some practitioners and surgeons are doing posterior approaches as outpatient as well, correct?
That is correct. You can have a posterior approach as an outpatient. That is correct.
Okay. And anything specific to the size of incisions or, blood loss or blood preservation techniques that have changed? I mean, we used to have people pre-donate blood for these procedures. That doesn't happen anymore, does it?
That's correct. We did that back a number of years ago. What we discovered was that blood that was donated actually wasn't very good blood come time when the surgical day arrived. So if you donated blood 3 weeks prior and then 3 weeks later you looked at that blood under the microscope, it didn't look like very good blood and didn't perform the functions of blood. So now we use different medications, particularly one called tranexamic acid, that we give patient by IV or locally in the tissues that significantly reduces blood loss during the procedure for hip replacement and knee replacement.
And so preoperative planning for these patients. So someone is indicated for an outpatient joint replacement. I think, a lot of people have concerns with, well, how am I going to be able to walk afterwards? What sort of stuff do I need to do to get myself ready for it? And then on the backside, again, we used to send people to rehab for a couple weeks, so you'd assume they need all this therapy. How are they getting prepared to leave the surgical center or the hospital that day?
So prior to patients coming to the surgical center, we do have a prehabilitation program that we give to every patient that's web-based and they could do on their phone or on their iPad. We could also print it out for people who don't want to use a phone or an iPad. Once in the surgical center, we have physical therapists there who will get the patients up with their first steps. We make sure that patients are able to walk at least 50 to 100 feet. Also, they have to be able to climb stairs. So the therapists interview each patient individually, ask them, how many stairs do you have to navigate to get into your home? Are there stairs to get to your bedroom? Is your bedroom on the second floor? Where's your bathroom? So every one of these patients is individually dealt with so that when they leave the center, they could navigate their home in an appropriate way.
That's great. And so do they end up doing some sort of home rehab as well? Does a therapist go to their house, or how does that work in the current day setting?
So it actually depends on the approach. For the anterior approach, we actually don't like to do a lot of physical therapy in the first month. What we found was these patients were developing some additional swelling and pain that was detracting rather than helping. So for the anterior approach patients, we actually have a web-based exercise program, which is very simple. And we maybe supplement that with a stationary bike. And that's all we want people to do for the first month. They come back for the second post-op visit in a month. At that visit is when we decide if a patient needs physical therapy. If a patient has a posterior approach, those patients are sent to physical therapy as an outpatient right from the beginning.
So can you just elaborate a little bit more about when you say prehab, what exactly are they trying to do? Is that specific exercises? Are they working with a therapist, or how does that work?
So we have a web-based program called My Mobility that is very individualized for each patient. They have exercises that are given to them to perform 3 to 4 times a week prior to the surgery. And this app is then used postoperatively for their postoperative therapy as well. What's also very nice about it, it has a direct texting feature, which is HIPAA certified, that goes directly to my nurse practitioner. So there's always an open line of communication to my office, both pre-surgery and post-surgery.
So that's great. No, that certainly gets people ready to go through this procedure. And even if you're having an inpatient procedure, I imagine that that's very helpful to have them prepared. So there was a recent video of a patient of yours that I happened to see scrolling through social media, where they're an hour or maybe an hour and a half after surgery walking up and down stairs. So I look at that, and I think some people may look at that and say, how are they doing that so quickly? Weren't they under anesthesia? Aren't they still having pain? Or maybe some patients feel like they might be having no pain at the center, but then develop pain later on. What can you tell me about that?
So the anterior approach specifically, because we don't cut any muscle, enables patients to get up at the very beginning and to function relatively quickly. The spinal anesthetic that we use is a very short-acting spinal that only lasts about maybe 45 minutes. Once that 45 minutes has elapsed, that patient's sensation and motor function has now returned. At the time of surgery, we do place some local anesthetic into the tissues so that some of the incisional pain is dealt with for the patient. But hip replacement in and of itself is an operation that is very well tolerated from a pain perspective. And these new techniques have just really enabled it to have a patient climb stairs and to be functional as they're leaving the center.
No, that's great. And that video was certainly quite impressive. What about, a lot of people are interested in sort of robotic surgery. Is that something that can be done as an outpatient at either a surgical center or at hospital?
Yes, certainly robotics for both hip and knee replacement has come a long way from its original variation. And you can have a robotic surgery as an outpatient. It doesn't affect the procedure in any way with that regard.
And so how about your sense of, or any literature, if you wanted to pull that in a little bit, of outcomes? Are there different outcomes based on whether it's done at an ambulatory surgical center versus a hospital? Or are there differences between costs on either side?
So one may find this hard to believe, but the outcomes for patients who have been selected to go to an ambulatory center versus a hospital for an outpatient surgery are actually better. Because when a patient comes to an ambulatory center, they're given extremely individualized care. When they come, many of them feel like they're the only person in the facility. Whereas with a hospital, it's a very busy place and patients don't quite feel the individual attention that they get at an ASC. Now, there is a differential for cost, and I don't think very many patients understand this particular topic. If you go to a hospital and have a hip replacement as an outpatient, or you go to an ambulatory center and have the same procedure, it's about twice as expensive to go to a hospital versus independently owned ASC. And that has to do with Medicare laws, in that hospitals are allowed to charge patients that much more for their procedure. And that's not just for hip replacement surgery. That's for blood tests, stress tests, or anything you get at a hospital is always going to be more expensive than if you went to a private doctor's office or an ASC.
That's very interesting. Yeah, it's something that certainly I'm aware of, you're aware of. We talk about it as practitioners. And so certainly something that, is very enlightening to patients who don't know about that. All right, Dr. Lombardi. So do you think the future is for outpatient total joint replacement?
I think over time, currently we're very conservative about indicating patients to go to an ambulatory center because we want people to be safe. I think as time goes by, we're going to find that more and more patients are going to be eligible and to be safe at an ASC. So currently, roughly 40% of joint replacements now are done on an outpatient basis. I would expect that number to be up into the 60% range within the next 5 years as we discover through proper research which patients are safe and which patients aren't.
And are there ever situations where you suggest to someone that they're a great candidate for outpatient surgery, but through whatever reason, maybe fear, that they say, hey, look, I really want an inpatient? And if that is the case, is that a problem from an insurance standpoint for that patient, or can they choose to spend a night in the hospital because of
Generally not. Insurance companies will approve the procedure, whether it is an ambulatory procedure or if it's a overnight stay. Certainly, I want my patients to be comfortable with their decision, and there are patients who are more comfortable with having an outpatient procedure in a hospital so that if they wanted to stay overnight, that choice is there for them. And in the end, we do what's right for each individual patient.
All right. I think that's all the questions we have for today and all the time we have for today. We look forward to everyone joining us for our podcast in the next episode.
Thanks, Steve. Thanks for having me.
Thank you for tuning in to the very first episode of the OrthoZone podcast. If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. We're excited to announce that our next episode will feature Dr. Charles Wong, who will be discussing the important role of nutrition in sports medicine. You won't want to miss it. Thanks again for tuning in, and we'll catch you next time.